As we approach the conclusion of this insightful conference, it's my honor to introduce our final speaker to deliver talk on a topic of critical relevance in neonatal care, utility of point of care ultrasound in crashing neonate. I invite Dr. Kiran, sir, to talk on this topic. Sir is a senior neonatal consultant and head of the department, lead for clinical research, MRR Hospitals, Thane. He has many awards and achievements. Among them, sir has done neonatal fellowship from Australia, formal neonatal and TN Echo Fellow at SickKids. Sir's areas of interest are neonatal hemodynamics, echo, POCUS, ECMO, neonatal ventilation, simulation, probiotics, developmental follow-up. Thank you, sir.
First of all, good evening, everyone, and thank you, NeoCORE team, for inviting me and giving this opportunity. This is a fantastic conference. I really enjoyed, and the presentations and all, everything was really excellent. I don't know if you have still energy left to listen to my last talk. So I'll just go over, it's just an overview of the how the POCUS can help in crashing newborn. Just showing the humble my experience just to build up the background. So I was fortunate actually to get trained in Mumbai and then go to Australia and worked in lots of different hospitals in Australia, then Canada, then New Zealand, Qatar, and humbly coming back to my own town, Mumbai, and BJ Wade is one of the alma mater considered as a prime institute in Mumbai. I was fortunate to head the unit there, 130 bed NICU. And currently I'm in a private hospital, which is also boasted as one of the largest in India. And in terms of my POCUS training, again, I feel very fortunate that I got exposed to a lot of good clinicians and ultrasound trained clinicians in Australia and formal TNECO program in Canada. And the also we established few programs in Qatar, in Wadia, and currently also we are running a joint program for POCUS training. The other thing, again, I'm trying to see, when I came back to India, the gaps which I saw, one of the other gap was the transport. So again, I did work in Western Australia, Melbourne, and in Canada for newborn transport. And then I was heading as a director for newborn transport in New Zealand with all paramedics. None of them are doctor, and efficient transport was done. And then I came to India, started my job in a trust hospital in Mumbai. My expectations that things would have been changed different in Mumbai at least, but to my surprise, I was getting crashed babies in rickshaws and taxis, and the worst experience was this. Can you see where is the baby here? So this blanket has got a 650 grams baby who was delivered and intubated, and this poor father is bagging this baby and grandmother accompanying. There is no doctor. The doctor was sitting in the front. And it's really sad to see such thing. We are talking about, I'm going to talk about POCUS, and that's the next level. I think the basic needs to get right first, and the babies don't come in good condition. So half of your battle is done, especially if you're dealing with the outborn unit. The babies don't come in a good condition. So all your expertise sometimes cannot pay off. So we did start some transport system with myself going for transports with a third party, and even this was one of the baby we retrieved from Tata Hospital, where there was no birthing. We created like a birthing environment and transported. And to go extra mile, I did work on building the transport for our new hospital. We designed this ambulance, which is state-of-the-art ambulance, which has got everything what we need, like a transport incubator, your T1 ventilator, one of the most advanced for transport, and defibrillators and multipara, everything. But coming to the topic, I think important is in any newborn is to anticipate early and pick them up early. If you don't pick them up at the start, and when they go out of control, then it's not going to help. Okay? The situation is out of control. Whatever you try, the baby is going to succumb. So every baby goes through journey of stable to getting into death. And the baby do give a lot of time, actually. So early clinical deterioration is something we need to pick up. Otherwise, the baby is going to face of sort of poor perfusion, worsening of the oxygen delivery, then the tissue level oxygen extraction goes up because of the babies getting sicker. You have your extraction in the brain and the tissue organ goes up. And baby trying to compensate in the early stages maximum as possible. And we need to pick up these babies in this early stage. But once they get decompensated, like your anaerobic metabolism comes in, lactic acidosis worsens, and you have your decreased oxygen consumption in the brain and the tissues, and then they get decompensated, you have multi-organ dysfunction, tissue necrosis, and the babies die. So whole idea about crashing newborn protocol or is about that you need to pick them up in early stage and your clinical might help, but a lot of time you need additional devices like point of care ultrasound, or if you have needs or non-invasive cardiac output monitor, they might help you to pick up these babies early, and then you might be able to save them better. And in many situations, you don't have access to those devices and you are solely dependent on your clinical acumen, and it might be too late before you intervene. So use of point of care ultrasound is not restricted to us. You can see now most of the other specialties have adapted it, like the pediatric cardiologist, obviously they're doing it, but emergency necophysicians and anesthetists also are routinely using it, and it's your visual stethoscope. So even before you auscultate, you can put the probe. And this focus point of care there's a soup of acronyms which have come up in different specialties. You have FEAR protocol, BLEEP protocol, RACE protocol, FATE protocol, FAST protocol. So why not newborn have some protocol? So crashing newborn protocol was built in using it is based on the safer protocol. But basically the idea is like even if you're not fully trained in the echo or point of care ultrasound, can you at least get trained to use the machine to quickly assess a baby who's become unresponsive or crashed, was otherwise well and crashed? In a quick assessment, you can look at different things. So it's a focus used by the bedside clinician, either pediatricians or the fellow or the resident or the neonatologist. And it's not replacing the comprehensive diagnostic specialties. Like obviously we're not competing with radiologist or cardiologist, but it's a targeted tool specifically answering clinical question to know what we are dealing with. Otherwise, you end up treating like a cocktail regime. So you need to know what's happening with that newborn. So, and particularly when the newborn deterioration is not known. So if you have an obvious cause, then obviously you don't need all these fancy things. But there are babies who might be well in the postnatal ward or in the NICU and suddenly crash, or they come from home and in crash state, or they're in a tertiary place where you don't know what they're going on. So then you can pick up with the help of POCUS. So this is the crashing newborn protocol, and basically it consists of broadly 4 organs you need to scan. So not only the cardiac focus, but also cranial focus, lung focus, and abdominal focus. And if you can look at the specific diagnosis, which at least these are the like bare minimum diagnosis, and like if you train yourself to pick up the spotters, like a pneumothorax or effusions or a sudden bleed or a crashed because of the tamponade or a PPHN baby or something like that. So that's the whole idea about the crashing newborn protocol. So focusing on the cardiac focus, most favorite for many of us, and I was very impressed with a lot of people presenting, the resident presenting with the talks, where their research topic is based on the focus, and then they were saying themselves are doing the scans. But again, like for the research, the training, the validity of the scans is very important, as rightly pointed out by many assessors. But for I think focus, it is about just at least making some presumption about the diagnosis and then acting on it. Just sharing the case. Recently, we had this baby referral from the government tertiary hospital, and baby was initially on a low setting CPAP, and then suddenly got worse, got ventilated on day 2, 100% FiO2, 20 on 5 pressures, saturations were only 50 to 60%, and family wanted to manage. pH is 6.9, 38, lactate 16, base X is minus 20. Now this is like, already looks like baby's gone into decompensated stage. We don't know the diagnosis because echo was not available. And baby is already on adrenaline, noradrenaline, and even sildenafil thinking of this thing. So any thoughts on the diagnosis?
Anyone? Sorry. Yeah, you said something. Pneumothorax, she's saying. Any diagnosis? X-ray is done actually. It was not, it was mild MS quite of picture, and I have given a hint like a black lung. No pneumothorax, but so PPHN likely, but not sure. But now SATs are 50 to 60%. And in a referral hospital, always a dilemma. Now we did not have a machine to quickly assess and decide what the fate of the baby, but we transfer the patient in a very poor state, 53%. And so we did suspect pulmonary hypertension crisis because despite SATs of 53, the heart rate was 170. That's an important clue. Baby, despite having hypoxia, not having a bradycardia, and that's why we know we hold our nerves during the transport and transferred the baby in such a low SAT state. And we needed to bag also multiple inotropes. All those things are important. So the moment, yeah, the baby came in, obviously we had a point of care ultrasound ready there, and as you said, it was a PPHN, and quickly we started nitric oxide, and again, in a crash protocol, you don't need to do the full scan. You just, even if you're able to identify the TR, or if not the septal flattening, if the septum is flattened, then you know that if the baby is systemic or suprasystemic. So again, this baby actually recovered well and went home despite coming in such a situation. And yeah, it completely recovered. There was basically multi-resistant Klebsiella, which actually flipped the baby into severe PPHN and required a lot of support, but went home with an intact survival with a normal MRI brain. Now this is again baby who's generally well, 26 weeker, first 48 hours in honeymoon period, doing well, and again deteriorated in the night and ventilated with 65% oxygen, desaturating, and metabolic acid respiratory acidosis. So again, no surprises here, but again, how the decision making changes. So this is the echo. Any comment on this? Again, I'm not showing the full echo, but just the comment. So PDA is there. Any comment on what type of PDA or what is it, and will you treat? It's a bidirectional shunt. So what you'll do now? Treat the PDA. How many want to treat? A few wants to treat. How many don't want to treat? Okay, there are a few hands not want to treat. So again, so you end up this dilemma in the morning rounds, and you want to know whether you want to go ahead and treat. Why this baby was looking very good in the night? What happened? Is it respiratory? Is it cardiac? Is it PDA contributing? All these questions come. Now, actually, you don't treat the bidirectional PDA when you have a PPHN. You allow the baby to settle down. Maybe the pressures come down. So you have to do respiratory management first before the PDA management. So I would not treat this baby, and I would do the respiratory management, maybe recruiting the lungs, shifting the baby on high frequency or the higher pressures, maybe sedate the baby and then get the pressures down. So same baby after day 5, day 3, again quick assessment. Now FiO2 has come down to about 35-40%. Still, but metabolic acidosis is there, respiratory acidosis is there, and now this is the echo. What will do? So is this ductus to treat or not to treat? Any comments on the pattern here? So again, I mean, I'm not trying to teach you the whole focus here, but the whole idea is, so this is a pulsatile pattern. It's a large ductus pulsatile pattern, which is a pattern of a hemodynamic significant ducts. I'm not going to talk about all the parameters here, but just a quick assessment also can tell you that this ductus has now changed from bidirectional to left to right shunt. Probably it's contributing significantly to metabolic acidosis. So you can consider treating it. Term baby with on ventilator, we had a PICC line and suddenly deteriorated. So pericardial effusion, very simple diagnosis. Sometimes you don't know what has happened, and obviously on a ventilated baby, we do go through a mnemonic of dope. But with dope, additionally, you can look at it. Sometimes some surprises do come. Okay, and this was one of the baby where we had to urgently aspirate. Otherwise, you would have crashed if you wouldn't have put the probe, because there was no antecedent. There was no cardiac history as such, but there was a big sudden this thing was there. Another dilated cardiomyopathy, 3 months old, suddenly crash at home, a febrile illness and presented with shock. You put the probe in the emergency room and you see such a dilated heart. right? So you don't need to be a cardiologist to look at this kind of a pattern that a heart is so dilated. Even in the four chamber view, you can see the heart is beating very slow and not really contracting very well. Then you know you're in trouble. Call cardiologist. Another one. So here again, yeah, you can look at the other parameters, specifically look at the fraction, ejection fraction, fraction shortening if you are trained, but just eyeballing also can pick up those things. This is another one. Recently we had it in NICU, in PICU. This was a little older, 2-month old with CCF. So even eyeballing can tell you that, you know, this heart is beating poorly and its myocarditis, the thickness is still preserved. So it's just myocarditis and not likely thinned out or a DCM kind of heart, but failure is there. Okay. And the other thing is like quickly sometime, you know, baby coming crash, you don't know the fluid status to look at the fluid responsiveness. If the IVC is collapsed or is it congested, just eyeballing also to help you to decide whether you want to give a bolus or not. You have to make sure that you don't have a failing heart and you have to make sure you don't have a very congested IVC before deciding for the bolus. Even if in newborns you don't calculate your contractility index and all those things, eyeballing also helps you to decide about giving boluses or not or fluid responsiveness. So fluid status can be further evaluated with looking at the four chamber view. As you can see here, this is little underfilled heart and this is a little overfilled heart. Again, your pulmonary and the ventilation status will decide, because sometimes if you are on a high frequency ventilation, the heart might look compressed. So that you have to take into account. But again, eyeballing can tell you about the fluid status. Going further to the cranial POCUS, again, common scenario in POCUS is that in the middle of the night, baby suddenly become sick and you know you have a 28-week developed crashed and developed shock. Now you always think about sepsis as a diagnosis and you start treating sepsis and you start inotropes based on that. But there could be a large bleed sitting here and sometimes this bleed could be significant, babies turn pale and that can cause hypotension and that can cause shock. So just putting the probe for a minute can tell you if there is a significant bleed bilaterally, because this baby actually extensively like it bled and further progressed to left side to grade 3 then eventually to grade 4. And then you know your decisions will change about your further management. Again, you know, we had a great discussion on palliative care, but we had a babies where, you know, in the night we were trying everything and then we saw on the ultrasound there was a grade 4 bilaterally. Obviously it changes your whole direction of management and talking to the family. So again, you don't have to wait for a formal head scan next day to decide what are you going to do. So you can talk to family about even redirection of care based on this. And the hydrocephalus and all those things doesn't come in the crash protocol, but because that doesn't happen immediately. Coming to the lung focus, again has come up recently, and something very easy to master and probably one of the easiest focus to understand. And as long as you have any of the probes which are available, like mostly you need a linear probe, preferably a hockey stick probe, and higher frequency probe, 15 to 18 hertz is preferable. You can do it. But if you don't have, even with curvilinear probe, you can do it. But important is that you need to have a proper settings of a lung ultrasound or a muscular skeletal settings we need to be there. Because lung ultrasound is one modality where you are not scanning an organ, but you are capturing some artifact. So basically you're creating those artifacts and you just sort of identifying some patterns. So it is a pattern recognitions which suggest normal versus abnormal. So all these reverberating artifacts which are created, so as you can see, coming in the slides, so you can do it in different regions, different segments, either 6 regions, 12 regions, and this is how you can do it. You can do it in a perpendicular position. This is commonly done because you will intersect different zones here, or you can do it in a parallel probe position also. And what you do is basically the whenever the ultrasound goes across the chest, it creates these reverberating artifacts. So you have these ribs here and the pleura, which is sharp, and then it will create these artifacts. So actually these lines don't exist. These are just artifacts, and it just tells you that the lung is normal and the ultrasound beam is able to pass and those artifacts are getting created. So then it creates something like a bamboo sign. So it indicates your pleural lines are smooth and your pleura is moving. You just look at your lungs are sliding nicely or not, and then you have a normal A lines which we called. Okay, so even if you look at A lines, you're reassured, okay, lungs looks normal. Even if you look at the lung is sliding, then it's normal. And this is how it will look. These are the additional signs. And there is again, you have to imagine, all these signs. Professor Linkestein, I think in Sweden, I think he's one of the first pioneers in lung ultrasound. I think he's one of the few people who started imagining these signs and actually saw them consistently as a pattern in normal versus abnormal lungs. So you have to train your eyes to identify this pattern. If you just look at it, it looks like a black and white, like, difficult to recognize, but it's a sand on the beach appearance. So this is the beach, and this is the sea, kind of the sea waves are there. So you can imagine this is a normal lung pattern. And again, this is like a bat wing. You have to really imagine hard how the bat will look like. But basically, the dark shadows are the shadows of the ribs, and these are the shadows in the lungs. So it creates like a bat wing appearance. And what happens? So this is just to show the normal lung sliding. This is how the lung should slide. So normal lung should move. So identifying the normal lines and lung sliding is good enough as a screening in the lung ultrasound. So if the lung is moving, that means probably it's a normal lung, and the pleura, there is a pleural space where there is no pathology. But suppose lung sliding goes in, then it goes into pathway of your pneumothorax versus pleural effusion. Then in the middle of night, again, RDS pattern is something difficult to sometime what happens, actually the baby is born and you've done the first x-ray, is not showing very classical RDS, and then baby gets deteriorated in 6 hours or 8 hours, and you're not sure whether the RDS is worsening, the x-rays doesn't look bad, you want to give a surfactant or not. So again, having some patterns, looking at different pattern recognition on the RDS is also helpful. So this is your normal A lines, but if you start seeing the B lines, which are the hazy lines, vertical lines, because what happens when the fluid comes in the picture, these artifacts will not appear. So the shadows of this pleura will not appear. So if you have a TT and like fluid in the lung, or lung which are immature with more fluid content like RDS lung, you will get this hazy or homogeneous shadows across the lungs, and those are called as vertical lines. These are vertical B lines, and there are different patterns which we identify, and there are these lung scores. Again, I'm not going into the details, but when you see, that's a separate sort of lecture, but basically when you see instead of A lines you see patterns vertical like this, then you know you are dealing with the RDS lung. And you can look at different segments, and there are different scores. So there are 6 segments you look at. There's a 0, 1, 2, 3, and then you can score it. But idea is that if you don't see a normal lung not moving, this kind of picture, you know you're dealing with a RDS picture. And this is again just trying to show more about how your C and the pleural line, the lung artifact, this is the beach. This is how it will look like. Now, when the pneumothorax happens, actually, the pattern changes into something called as a barcode sign, and there is a often differentiation you can see. There is a one lung which is normal and the portion of the lung which might be abnormal. So again, if you put an M mode and you see something like a barcode, that might suggest you there is a pneumothorax. Again, there is yeah, just I think one slide I have skipped. Other important thing in the pneumothorax is the lung sliding will be absent. So absent of lung sliding and an M mode, there is a barcode. These two things can pinpoint you for a identification of the pneumothorax. Now pleural effusion, again very easy to identify. Now a lot of time the pleural effusion evolves over the time, but we had encountered situations like chylothorax or hydrops fetalis in the delivery room not responding. You have done intubation, you're bagging, and you're not able to ventilate this lung, and then you put the probe and you see there's a lot of fluid place both the sides, and we had done like a chest drain insertion in the delivery room, which helps this. So again, putting the especially in the basal region, and if you see there's a fluid collection, that can diagnose your pleural effusion. So again, you can see there is something called as a jellyfish sign, because you can see the flapping of the lung inside the fluid. So if you see this fluid collection, the fluid will appear dark. So this is the liver here. Often you do it in the baseline, and then you see the fluid jellyfish appearance, and you put an M mode, you see something like a sinusoid sign. Again, there are ways you can quantify, but Just identify diffusion, quantify if it's mild, moderate, large, can help you to decide whether you need an urgent tapping or not. This is again, yeah. Now, central line focus is not part of the crashing protocol, but again, recently we have seen migrating lines a lot. Again, one of the case I showed, the line actually migrated inside and caused even pericardial effusion. So even focus just to identify the lines is important, especially if they are migrated into the liver or they have withdrawn. Sometimes you have a baby who gets hypoglycemic or hypotensive, and there was an umbilical line, and this is maybe a common scenario. The umbilical line has moved out, and the fluid has extravasated inside the liver cavity. You have a big fluid collected there. So this is where again, whenever there are umbilical lines, they are notorious in migrating. So if your baby is crashed, first check your access, look at the umbilical line is in place and you're delivering, especially if there is a hypoglycemia or sugar dropping. So partially the fluid is going inside the body, and then partially it is getting collected in the liver or sometimes extravasating. That's also very much notorious for the babies to crash. So you can look at the location, and x-rays can be deceiving. Many times the x-ray are superimposed, especially the epi x-rays are superimposed, so you might get deceived. So you can look at the location of the lines where they are. And so yeah, abnormal UVC tip, they can go into the parenchyma, they can migrate, or they can sometimes go into the heart as well, all those things. So UVC tips are often notorious to migrate. USC tips you can look at in the aorta, and some things, sometimes you can start seeing some big clots coming along, that sometimes can cause blocking the perfusion of the lower limbs or spasm in the lower limb. So again, whenever you have a lower limb perfusion issue, look at the USC tips. If there is a clot happening, or if the tip is migrated, or tip is close to any of the arteries, all these risks you can identify with the focus. And again, difficult IV access in a baby who's coming crashed again in a hypotensive phase or shocked. Often you don't find the peripheral lines, and we do obviously a focus directed lines insertion, and even in the ER sometimes we use the focus to insert the line. So that is something again important for sort of technique you can learn. And if you have a proper hockey stick, this is a uh, proper vascular flow. You can visualize the vessels. You can do neck lines, femoral lines, even peripheral lines in a bigger, like 3 kilo babies. You can visualize the peripheral lines if you have a proper machine in the emergency. Now, last but not the least, and not one of my favorites, and I think this is something little difficult to master, because abdominal is a lot of gray areas are there. Abdominal focus, especially, these are the few things you can look at, like the bowel thickness, perfusion, and there is a free fluid on the peristalsis. So grossly, when you put the probe, at least you know if the bowel is looking healthy, the bowel is moving okay, and if there is no free fluid. Grossly, you can identify, but obviously there is a large bowel you have to interrogate. So in a quick assessment, many times you might miss few things. So always you can decide few things in the emergency, especially if there is a clear big fluid or there is a peritoneum, then all those things ultrasound can help you. So but yes, you can look at if the lumen is okay, if this echogenicity is linear, if there is a mucosa, then there is this color dots flows in the arteries. If you see this color dots flowing, then you know the bowel perfusion is okay. If the dots are less, then probably the perfusion is affected. Again, you need to train yourself to look at this. And yeah, hypoechoic muscularis. Then bowel thickness is something again can be mastered. If you start looking at bowel walls regularly, then you know if the bowel wall is thickened, or if there is a thinning of the bowel, all those things. So this is the bowel thinning. So you can see the bowel is thinned out in one particular area, and this is and less than 1 millimeter is really thinned out. Probably there is a precursor for pneumoperitoneum. This bowel might rupture any time. And again, identifying intramural gas. So this pattern, when you see this kind of a pattern and the lung abdominal ultrasound, very classical kind of a, you can differentiate. You have intramural gas or intraluminal gas. Okay, so this is thickened layer with the wall with the intramural, and this is intraluminal gas. And yeah, free gas in the peritoneum also can be this thing, but again, X-ray probably might be a quick modality, because air is difficult to locate on the ultrasound. So probably X-ray might be a better modality for intraperitoneal gas. But for the fluid, Yes, free intraperitoneal fluid, and if there are, especially you can see there are these sediments or what debris is there, then you know there is definitely something has gone. Probably the baby has perforated, and there is a lot of this fecal or material there in the abdomen. So these babies can be acted upon, and surgical reference can be taken. So there aren't enough cardiologists or radiologists in the world to meet the needs, our needs of neonatologists or pediatricians, and especially in the after hours. And I think that is probably has led all of us to get ourselves trained. And I think this is not only in the smaller centers, even the big tertiary centers also, we face this issue. So I think getting yourself trained with at least these basic things is a very useful modality. And this crashing newborn protocol, I think it's very useful for
Thank you.
diagnosing at least the gross diagnosis of certain pathological conditions in the newborn in different organs. So if you go focused, then it will help you to reach the diagnosis quickly. And I think we neonatologists have moved beyond PDN and PPHN to more doing focus now. So, I think we used to get humiliated in Australia. Oh, you're a PDA doctor, when we used to do scans. So we're not PDA doctors anymore. So more you get used to the machine, you can not only do this, but you can do tracheal, like your ET placement, even your optic nerve thickness, and your lot of other things you can do with the lung ultrasound. Your bladder is empty or not, all those things. So get used to using this machine. And obviously we still have to work with our cardiologist and radiologist to have a final diagnosis. But in the case of emergency, I think the crashing newborn protocol will help. So I think more and more of us should get skilled, and that's, I think, looks like a need of an hour. Thank you. With that, I'll stop.
Yeah, it's nice talk, clear. We are open to questions.
This is just an overview, so I'm not going into
Yeah,
detail or anything.
he tried to cover full focus
Full
in
focus in
45
one.
minutes. So, yeah, if there is no question, I think
No
we can.
question. Either is clear or everyone is exhausted. Okay, thank you very much.
Thank you.